Thank you very much for the invitation to speak at the Harvard Anesthesiology Update 2020. I'd like to thank Kira Mason and Sugantha Sunder for the invitation. Today I'm going to talk about aspects of head and neck anesthesia, but in particular I'm going to talk about thyroid surgery and the new guidelines on management of hematoma after thyroid surgery. I have some affiliations with various colleges, the Royal College of Anaesthetists in London, and I'm past president of the Irish College of Anaesthesiologists, and I'm the Airway advisor in that college. I've been involved with the Difficult Airway Society for many years, and I'm now the International Liaison Officer. I'm on the boards of other airway societies, including the Society of Airway Management in the US. So I am a consultant anesthesiologist at St. James's Hospital in Dublin, affiliated to Trinity College Dublin. At this hospital, we do a lot of cancer work, and in particular, head and neck cancer cases. We do about 250 cases per year. We also have a regional maxillofacial unit, a national burns unit, and I run the Advanced Airway Fellowship and Simulation Program. So what I'm interested to talk about today is thyroid cancers. And this work from the US shows that thyroid cancer represents 3% of all new cancer cases in the United States. So it's quite a common cancer. At St. James's Hospital, where, as I say, we do a lot of head and neck cases, we tend to do the more complicated, like total thyroidectomies, partial thyroidectomies in patients with cancer, and the large retrosternal goiters, because we have the cardiothoracic backup. We do approximately 200 of these type of more difficult cases per year. Now, what's the incidence or prediction of difficult intubation in thyroid surgery? This was a prospective study looking at 320 patients, and difficult intubation occurred in 17, or 5.3%. Easy and minor difficult intubation more common, and minor difficulties in about 58% of this cohort. Cancerous goiters, or Coleman-Lehan 3 and 4, were independent risk factors for difficulty. And the goiter size did not impact on difficulty of intubation. Cancerous goiters are a major factor in predicting difficult intubation. And this is another study looking at anesthesia for massive retrosternal goiters in a tertiary referral centre quite like ours. And they looked at 573 cases over 5 years. There were 34 retrosternal goiters. 19 were deemed massive retrosternal goiters. There was 1 case of failed intubation, no sternotomies, and no post-op respiratory problems or tracheomalacia. And the editor's key points with regard to this study in the British Journal of Anaesthesia suggest that patients with massive retrosternal goiters may present difficulties, obviously, with airway management, and specific problems with tracheal intubation, post-op tracheomalacia. But opinion on the optimal anaesthetic management is divided, and that's a theme. How to manage these patients, the anaesthetic manager is quite divided. But a technique of IV induction, direct laryngoscopy, and tracheal intubation was successful in 18 with the benign multinodular goiters, but the patients with cancerous goiters are more challenging. What about tracheomalacia? Another paper in the BGA looking at post-thyroidectomy tracheomalacia. And the points here were that tracheomalacia can occur after goiter surgery, but its reported incidence varies. And in this series of 334 patients, 62 had tracheal compression, but there were no cases of tracheomalacia. And again, to re-emphasize the fact that tracheomalacia after thyroid surgery is rare in contemporary UK practice, and that is similar to our practice. Now, I mentioned the clinical management of these cases can be varied, and Tim Cook, airway anaesthetist in the UK, did this little kind of expert opinion survey, which was interesting. He presented a case of airway obstruction caused by a retrosternal thyroid mass to an international expert group. And this is the case he sent to this group. It's the case of a 59-year-old female with inspiratory stridor, with a BMI of 30 and presented with mild shortness of breath on exertion. She had a retrosternal thyroid mass, compressing the trachea in the midline and dividing further down into 2 or 3 lumens. The nasendoscopy on this patient was normal to the vocal cords, but the CT showed a pretracheal mass extending from C5 to T2. And she was scheduled for urgent total thyroidectomy because clinically she was deteriorating. And here you can see the 2 small discrete lumens, narrowest at T1 and very narrow at T1, and hence the reason for the urgent thyroidectomy. And these scans are, as you can see, are quite impressive. And these were sent along to the international expert group. They were asked, how would you intubate this patient? What was your plan A, your plan B, and your extubation plan? And it was sent to about 14 experts, all involved in the Airway societies, all very published in this area. And there were 4 responses from UK anaesthetists, from the Difficult Airway Society, and 4 from the Society for Airway Management in the USA. And this is just a summary of the expert opinions on the case management, on the induction, the plan B, and their extubation strategies. And just on a glance, you will see, particularly with regard to induction, that the plans varied with all the experts. And they came back with quite detailed explanations of why, and literature searches and so forth. But almost half would do inhalation, IV, and there were 4 who would do an awake fiber optic. So very varied intubation and induction strategy. Plan B was quite similar in that most involved a rigid bronchoscope, and the extubation plans varied as well. And the point, I think, that was made by the authors that for every expert, there's an equal and opposite expert opinion. So can we always believe expert opinion? And what was done in this case was an awake fiber optic with an entry intubation catheter and a tracheal tube, which was the intubating LMA tracheal tube. The plan B was an IV induction with neuromuscular blockade and intubation, and followed by rigid bronchoscopy. And the extubation plan was the insertion of an LMA and fiber optic inspection through it to exclude tracheomalacia. So I would have thought very reasonable. And to do that, they used a Remy fentanyl infusion of 2 nanograms per mil, a spray-as-you-go technique with lignocaine 4%. They put the fibroscope with the entry catheter and a 6.5 tube over that, and extubation, as I said, an LMA and inspection of the vocal cords. Now, this is the entry catheter. I have to confess I was involved with the design of this, but don't get any monies from it at all, so no conflict of interest. But it is designed to fit over your fiber optic scope to enable you to place the fiber optic scope, and it fits snugly over it, and to place this catheter into the trachea. And it has, you have ability to ventilate through this or jet ventilate through it as well. And what they did was use this over standard 3.8 millimeter fiber optic scope. And that you can also use it over the Ambu Slim scope, which is 3.8 millimeter. It's important to use an ET tube then when you're railroading over the entry catheter that fits snugly. So you have the choice of a Parker Flex, the intubating LMA ET tube, which is what they used, or a reinforced Mallinckrodt. And here are the 2 at the end. The one at the end is the intubating LMA ET tube. It's nice because it's got a nice soft silicone tip which fits snugly over the entry catheter. This is a patient of mine that got given consent, but he was intubated using a reinforced Mallinckrodt tube over the entry catheter, again awake. Extubation included the Bailey maneuver, which is extubating the patient deeply, putting in your LMA. This is the ProSeal LMA they used, and then inspecting with the slim scope through that, inspecting the trachea for tracheomalacia. So I think the comments here were the opinions differed markedly, mirroring the published literature on managing retrosternal thyroid masses. As I said, 4 experts from the USA and 4 from the UK. And it does raise questions about expert opinion, and it does raise questions that when these cases go wrong, the expert's opinion can vary. One other point I'd like to make is Plan B was always using the rigid bronchoscope, which is excellent. But remember, you must have the skill, or must have a surgeon in the room with the skill to use that. I'm now going to just talk about these very recently published guidelines on managing hematoma after thyroid surgery, which were published in November of 2021 in anesthesia. They were multidisciplinary consensus guidelines. The ENT UK group were involved, the British Endocrine and Thyroid Surgical group were involved, and the Difficult Airway Society, to bring all the people involved in this work together. And they're excellent guidelines. But by way of background, guidelines often emanate from something that's happened, and particularly in the UK, where we have coroner's reports on clinical cases. And this clinical case set the scene for these guidelines, unfortunately. This is this case of a 50-year-old lady who presented with a breast lump, but coincidentally, she was found to have multinodular goiter. It was recommended that she have surgery for that, and to expedite things, they decided to do both operations jointly. So during surgery, the goiter was found to be quite large and toxic, and took 3 hours duration, with blood loss of about 1,500 mils, which the average is about 20 to 100 mils for multinodular goiter surgery. She was discharged late in the evening, and at about 1 in the morning, the staff were alerted about swelling. She deteriorated quite rapidly. There was no respiratory arrest. She went into pulseless electrical activity, and she developed spontaneous circulation with CPR. And repeated attempts to intubate, however, were unsuccessful. So the surgeon arrives about 15 minutes later. He opens the neck hematoma, and then they successfully intubated this patient. She returned to theatre for washout and tracheostomy, and then returned to the ITU, where over the next while she was diagnosed with severe diffuse ischemic cerebral injury. Neurohab commenced, and she died sadly 7 months later. So this is a tragic case of a death from a bleed following benign thyroid surgery. There was a coroner's inquiry, which takes about a year, and this was published last summer. They described multiple level systems failings, as is always the case. Human factors is very much involved, and a possible preventable death. But there was recommendations from the coroner's inquiry that there should be improved safety protocols, improved awareness of post-op bleeds after thyroid surgery, improved understanding of how to manage this complication, and that learnings from this case should be formalized. And the coroner's reports tend to write to the various bodies, like the colleges of surgeons and anaesthetists, to see what they can do. So this led then to the development of the guidelines. Now, hematoma, we know, develops because pressure builds up because of pharyngolaryngeal venous system congestion, and pressure builds up in the venous system. The trachea is rarely obstructed. You also tend to get a neural response, which is of the respiratory system, and this has been shown in studies in animals. So I think we must discuss the treatment. And before even the guidelines were done, this protocol, the SCOOP protocol for evacuating a thyroid hematoma, were developed by a group in Oxford. S stands for skin exposure. I also say it for surgeons, because you contact the duty surgeon if they're available. So skin exposure. Cut, C stands for cut the subcuticular sutures. Push the fingers into the wound, then O for open the skin to expose the strap muscles, and open the strap muscles to expose the trachea, importantly, and then cover the wound with a pack. So that's the SCOOP protocol for evacuation of a thyroid hematoma. But why do we need guidelines? We need guidelines because post-op hemorrhage is a well-recognized complication of thyroid surgery. And interesting enough, I had one yesterday in my ENT list. In fact, it was a parathyroid case, and we had to evacuate a hematoma immediately post-op. So it is a well-recognized complication of thyroid surgery. 25% of these cases result in airway compromise. But guidelines aim to improve patient safety through training in the recognition of this problem and the management of it. And no previous multidisciplinary team consensus guidelines have been published on this topic. Remember that this can occur in more remote areas with higher patient to staff ratios, less frequent monitoring, and lack of immediate access to appropriately skilled staff, because thyroidectomies are considered low risk and done in various settings. There's a risk of rapid clinical deterioration in the event of even a small hemorrhage, especially if laryngeal edema. And remember that these principles may apply to other types of neck surgery, such as parathyroid, which is, as I said, case I had yesterday, but cervical, spine, and or vascular surgery as well. So these guidelines and principles refer to those as well. And monitoring, remember, it usually occurs within the first 24 hours following thyroid surgery, with approximately half occurring within 6 hours. That's when the hematoma occurs, so monitoring must occur for those times. Routine patient observation must be carried out hourly for the first 6 hours, and this is grade C evidence. And following the initial 6-hour period, the frequency of observations may be tailored according to individual patient risk. Patients are commonly discharged 1 day following surgery, but that is changing, and there are more cases now being done as day cases. Now, monitoring should be done with the patient near the nursing staff and by staff trained in recognizing and managing the hematoma. And it should include wound inspection, early warning score, which is respiratory rate, heart rate, SpO2, etc., pain scores, and awareness for the more subtle signs like agitation, anxiety, discomfort, and difficulty breathing. And this is a summary of those guidelines, which can be found in the anesthesia journal. But basically, patient requires close post-op observation. And we have this acronym, DSAT, which does stand for difficulty swallowing, the mu score, swelling, anxiety, tachypnea, difficulty breathing, and stridor. So DSAT, this will pick up early signs which need urgent senior clinical review. And remember, desaturation and increased oxygen requirements is a late sign of airway compromise. And if review reveals any of or more of the above, you should start with oxygen 15 liters per minute, nurse the patient 45 degrees head up, and then continue to think about evaluating and evacuating. And again, to stress that these should be done hourly for 6 hours. And you may consider a flexible endoscopy to look for edema, IV dexamethasone, or tranexamic acid. You must get your post-thyroid surgery emergency box at the bedside during transfers. This will have your artery clip, your guidelines on how to treat, and the scoop protocol, a scalpel, a scissors or a staple remover, and sterile gauze or a wound pack. And remember, emergency front of neck airway equipment must be at hand also. Immediate senior surgical review is very important, and this has been some of the failings and some of the morbidity and mortality related to this, not getting senior surgical review immediately, and then senior anesthetic review also. Oxygenate while you're evaluating, and if airway compromise, open the wound at the bedside with scoop. And again, this is the scoop protocol for evacuation, which everybody should be familiar with. And that's what we did last night when I was called back for my bleed. We initially evacuated the hematoma. However, post-evacuation, if the patient is stable, surgical team can discuss with the patient, because remember, it is quite distressing, perhaps, having your neck opened awake and so forth. And this is the full protocol. So you evaluate, you evacuate, and then if the patient doesn't improve and is not stable, you proceed to intubate. And again, that failing, you go to EFONA. If the clinical presentation is appropriate, you can do awake tracheal intubation. That would be my first choice if the expertise is available. If life-threatening airway compromises emanate, intubation should be attempted after opening the wound, which will make things a bit easier. Remember to use a smaller tracheal tube and use adjuncts like bougies and so forth, and confirm with capnography. And there's good evidence for this. In my case, she was an easy intubation first time round. She had after evacuating the hematoma, her breathing was better, so I used a microlaryngeal size 6 tube over a bougie. Now, Emergency intubation must be considered regardless of patient location, but if you have time, best to take the theatre, which is what I did. Videolaryngoscopy is recommended at first attempt, and there's evidence for this. And again, limiting the number of attempts, and early progression to front of neck access should be considered. And if that's the case, you should consider scalpel, cricothyroidotomy, preferably with a size 10 scalpel and a bougie and a size 6 tube, which fits over your bougie. So this is our protocol, difficult airway site protocol for Plan D emergency front of neck access. Continue to give oxygen, ensure neuromuscular blockade, and position the patient with an extended head. And hopefully at this point, you may have a surgeon there as well. And this is a core skill for all anesthesiologists. And in our operating theatres, we have this kit on every anaesthetic machine, so immediately available, and it's also in the scoop boxes. Remember team training and skill retention. All members of the multidisciplinary team, staff dealing with patients having thyroid surgery should be trained to recognise and manage post-op hematoma. High evidence for this. It should reference the post-thyroid surgery emergency box and its contents. Teaching should ideally prioritise simulation, and individual training should be repeated every 3 years at a minimum. And the risk of hemorrhage after thyroidectomy, as we said, is high. It's 1%. And studies suggest it leads to acute airway compromise, necessitating bedside intervention in 1 in 400 thyroidectomies. And remember that patients should be warned of this as part of the surgical consent process. And the question then is, should thyroid surgery be done as day cases, which is increasingly the case now in many centres. But this decision should include a discussion with the patient about the possibility of hematoma at home and subsequent action at home, including a printout of the scoop poster. Also remember, perhaps when consenting patients, that the number of thyroid operations performed by the surgeon is inversely correlated to the complication rate. So the more thyroid operations a surgeon performs, the less likely a complication will occur, such as bleeding, voice changes, and damage to the parathyroid. And this is been shown time and time again. Now let's look at this retrospective cohort study of all consecutive patients who underwent thyroid or parathyroid surgery over a 7-year period. And this looked at over 1,900 patients. And 25 had reoperations for bleeding. So 1.3% had reoperations for bleeding. Your risk of bleeding was much higher after total thyroidectomy than partial thyroidectomy, and higher for total thyroidectomy compared to parathyroidectomy. And 24%, quarter of those who bled, needed reopening in the operating room. 68% within 6 hours, 4% within 4 to 24 hours, and 4% within over 24 hours. And patients who had reoperations had longer length of stay, similar rates of recurrent laryngeal nerve palsy, wound infections, and hypoparathyroidism. So new protocols were created to reduce the risk of bleeding and for early bleeds. This is the scoop protocol. Now beware the oozy Graves' disease thyroids. And although my case yesterday was parathyroidectomies, the thyroid was found to be quite inflamed. And I think it was similar to kind of a Graves' disease type thyroid. Post-op communication, the potential risk of hematoma should be highlighted during the sign out in theatre before returning the patient to the ward. It should be cascaded through the various handovers, and particularly when transferring to the PACU ward, as I say. The emergency boxes must go with the patient. They can be made up simply from type like lunch boxes with the scoop protocol, with your scalpel size 10, with your scissors as well to open the wound. And they should stay with the patient and return them to recovery on discharge. They're quick and simple to make up and cheap, and they can be returned after use. Remember training, and particularly simulation training as a team is very important. So we have started doing this particular scope sim with the multidisciplinary team at our hospital, the surgeons, the recovery staff, the ward staff, and the anesthesiologists. And this has been started now since the guidelines have been published. If you go back to the Anesthesia Journal, you will, and the ENT UK website or the DAS website, you will see the guidelines, the supporting resources to aid implementing these guidelines. Guidelines are only of any use if they are implemented and there is regular ongoing teaching. So I'd like to thank you very much for your attention. And if you have any questions, I will answer them at the end of this session. Thank you very much.